rounds. Bernadette Tobin is my name from the Plunkett Centre for Ethics. I'm the chair of today's session, and I would like to remind you, first of all, to mute your microphones and your cameras. I think I can see that everyone has their camera muted. I'd like to remind everyone to register attendance at the beginning of the session. The registration link and QR code will be posted in the conversation tab shortly. Now, our guest speaker will happily take questions at the end of his presentation, either in the conversation section on the side, or you can use that little hands up tab if you like, and I think I'll get to see you. So I'd like to introduce today's speaker, Dr. Bill Sullivan. Bill is joining us from Toronto, Canada. Bill is a family physician, a fellow of the Canadian College of Family Physicians. He's a clinical teacher at St. Michael's Hospital in Toronto and at the University of Toronto. His medical research is primarily through the Developmental Disabilities Primary Care Program of that university, and he's the director, the founding director of that research program. Bill also has a PhD in philosophy from the University of Toronto. He teaches medical ethics to the residents of St. Michael's. He's currently chair of the Committee on Ethics of the College of Family Physicians of Canada, and he's led their, the development of their Teaching Ethics in Family Medicine handbook, as well as their guide for reflections on ethical issues concerning assisted suicide and voluntary euthanasia. Bill is also a member of the ethics committees of both the Canadian Medical Association and the Royal College of Physicians and Surgeons at Canada. And finally, Bill is the founding director of the International Association of Catholic Bioethics, and he chairs its academic committee. And I can tell you, as a member of that academic committee, it meets at the very convenient time of 10 p.m. on a Saturday evening, Sydney time. So I'm very grateful to you, Bill, for joining us 10 p.m. Monday evening on your time. It's a little bit of a punishment for all the 10 p.m.s you've inflicted on us here in Australia. So, Bill, I welcome you. And Bill's subject is the question, ableism, is it a malady of modern medical decision-making? Over to you, Bill.
Well, thank you very much, Bernadette and colleagues. It's a delight to be here. I would say good evening, but perhaps I should say good day. So as mentioned by Bernadette, I'm have these various relations. I should just also qualify one thing that she kindly noted was my connection with the Canadian College of Family Physicians Ethics Committee, and I've finished that role now. So, but these other roles are still active, and I have no conflicts of interest. So I thought I would begin by just indicating some objectives for this session. And I'm hoping that by the end of the session, you'll be able to describe and mitigate ableism regarding people with disabilities, particularly in medical decision-making, and to do so in 4 ways, which I will explain in my talk. So don't worry about what these things mean right now. So I thought it would be helpful to start with a story of actually a real patient, actually, slightly modified. The patient's name is Tim, and he is a single male with an intellectual disability that's in the severe range, and 3 to 6 means a mental age equivalence of a 3 to 6-year-old. Important to remember that because in the profound range, it's 0 to 3. And further in the talk, I'm going to be talking about a few other people in the profound range. So Tim has limited verbal communication. He has a few words and uses gestures. He enjoys swimming, art, friends, and prayer. Lives in a group home with 6 others. He has one brother, but he lives 6,000 kilometers away. He needs help with some of his activities of daily living. And he has only his only supports are group home staff and a social worker. So what happened soon after COVID began here in Canada was he quickly became ill and was admitted to hospital with severe symptoms. And at that point, there was lockdown, and so only family members were allowed. That was the policy at the hospital. He was assessed to lack decision-making capacity on admission. He was short of breath, and he certainly wasn't at his best, but it was obvious that he didn't have decision-making capacity. And the way our law works is that there is a hierarchy of substitute decision makers, and at the top was the brother, who was contacted from the hospital by phone. He didn't even, I don't know if he even knew his brother was ill at this point. And what he was told was that his brother was too frail. At that point, people were talking about a frailty score, applying it to people with intellectual disabilities. And not likely to benefit from critical care interventions. And the suggestion was what we call do not resuscitate, or do not attempt cardiopulmonary resuscitation. So for a moment, just pause and think about putting yourself in Tim's situation. How might Tim be feeling? As Tim's physician, how might you involve him better in decisions regarding his care? So the situation I just described, I believe ableism was involved. It is too often a malady of modern medicine. So what do we mean by ableism? It's a prejudice that devalues persons with disabilities because of their impairment. And it can be overt, or covert. So I'm glad that in person-centered care generally, we try to avoid paternalism in medical decision-making with patients who have decision-making capacity. We offer the green column and avoid the red. But what if the patient has an intellectual or developmental disability, dementia, or a psychosocial disability? And this is not an insignificant number of patients in all our healthcare systems. That in Australia, the numbers are here, and this refers to people with severe or profound cognitive limitation, like Tim. And I just want to say that this might not sound like a big number, but if one was to find out the amount of resources that go to this, we call it the top 5%, it's significant in healthcare systems. So even though the law presumes that adult patients will generally have decision-making capacity, for patients with cognitive impairments, paternalism is a risk and driven by ableism. As a society, we've made significant headway in valuing people with disabilities. However, I believe ableism still persists and often goes unnoticed in medical decision-making because it is embedded in routine practices and policies. For example, ableist assumptions underlie the way in which decision-making capacity is typically assessed. And many healthcare organizations fail to offer what's been referred to as reasonable adjustments for decision making, even though such adjustments are required by law for people with disability in order to receive services that are essential. Now, what do we mean by such reasonable adjustments? Here are some examples. Adapting environments or adjusting practices to meet needs of patients with disabilities, as in the first bullet. And going down to the bottom of the list, one of the most important adjustments is enlisting help from close carers and other decision-making supporters who know the person well. The right of persons with disabilities to reasonable adjustments and supports in decision-making is recognized by the UN Convention on the Rights of Persons with Disabilities. The convention recognizes all people with disabilities as, first of all, persons before the law, that they should be enjoy legal capacity on an equal basis with others, and that parties shall take appropriate measures to provide access by persons with disabilities to the support that they require in exercising their legal capacity. My focus in this talk will be on ethical considerations for promoting patients' decision-making capabilities. And I will be drawing mostly on the International Association of Catholic Bioethics colloquium that was held in Quebec last year, and a soon to be published consensus statement on this very topic. Bernadette Tobin and another colleague from Australia, Kay Willem, were both participants. Key ethical considerations that are articulated in that consensus statement are first, respect for human dignity. Second, solidarity and accompaniment in decision-making, which recognize human relationality and interdependence. And third, discussing and honoring, or discerning and honoring authentic human values as the basis for patients' healthcare decisions. These are 3 of 5 such principles that are articulated at the beginning of this consensus statement. So for the purposes of this talk, I want to highlight 3 barriers to living by these ethical principles that are often covert but commonly accepted practices and policies surrounding medical decision-making. And since I come from Canada, I'll be referring to these using images of 3 different bears: the polar bear on the left, the grizzly bear in the middle, and the black bear on the right. And these are in order of most menacing to humans. And I say I'm going to be poking at these bears because in the time we have, I might just make them mad. And but at least I hope to make the point of what's at issue. So for the polar bear, the view here is actually an ethical one. That to be capable, one needs to be able to demonstrate only intellectual skills. The second bear is actually taking on a legal presupposition, that is, capacity is the same as being able to decide independently. And the black bear is sort of taking on medical practice, and it's this idea of a certain model of the doctor-patient relationship that is applied to people with disabilities called the consumer model. And in this model, one provides care without support to deliberate on ends means reasoning. So let's begin then by talking about the first bear of ableism. So my PowerPoint seems to be a little stuck. Sometimes it just takes a moment and I'll be patient. The first one has to do with that legal capacity is typically related to the ability to demonstrate only intellectual skills. So in Australia, as in many countries, assessing legal capacity in healthcare requires patients to demonstrate certain intellectual skills with respect to certain decisions. And either they have these skills or they don't. So, so I think that what is missing typically is that capacity assessments attend to a patient's capacity, do not attend to a patient's capacity to feel, which is the basis of their judging and pursuing values. Certain feelings, those responding to authentic human values, are significant in decisions that we all make. And I'm quoting here from the Canadian philosopher and theologian Bernard Lonergan, who said that the whole mass and momentum of living is in feeling. And famously, in one of his works, of the collected works, he speaks that of values as being apprehended in feelings. So,
I don't know if it would help, Bill, if Laura took over the slides.
Okay.
I don't know. Laura, are you able to do that?
Bill, would you like me to put version 2 up for you? Would that help?
If you could, that would be great.
Okay, let me do that in the next 2 minutes.
Okay. Now, unless I just get out of the sharing of my screen. So let me continue, because the next thing I wanted to talk about is the testimony of a philosopher. Her name is Eva Feder-Kate, regarding her daughter, Sasha, with a severe level of intellectual disability.
Bill, if you want to signal to me, and then I'll...
Yes, and this is slide 15 now.
Yes.
So Sasha now lives in a group home with 5 other severely to profoundly mentally retarded or multiply disabled individuals. So the next slide. Not one can even remotely be described as entirely unresponsive to their environment or other people. Oh, next slide. I am greeted by smiles and acknowledgements of some sort when I arrive. At our home, listening to the Emperor Concerto, she gazes out the window enthralled, occasionally turning to us with a twinkle in her eye when she anticipates some really good parts. So, in terms of understanding and reasoning about medical decisions, Sasha would likely be assessed to lack decision-making capacity. But Sasha is capable of indicating the values that make her life meaningful. These are important to reaching medical decisions. So what does Sasha value? Friends, relationships, mother, beauty in music? And how would she communicate these non-verbally to people she is close to? Next slide. So this brings me to the second ableist barrier, which is that capacity equals being able to decide independently. Next slide. And I want to share another testimony, and this is from someone named Audrey Cole, who is the mother of Ian. And Ian has a profound level of intellectual disability and other disabilities. And Audrey was a participant in the IACB colloquium in Quebec last year, and and she influenced the Article 12 in the UN Convention on the Rights of People with Disability. So this is what Audrey says. Few of us could say that we have never sought help or advice in making a decision. As long as our decision-making capacity is not questioned in the legal sense, we are free to seek and use whatever help we need in reaching decisions. This is not so for people whose cognitive capacity is questioned. So regardless of the complexity of decisions to be made for people with cognitive impairments, help from those close and trusted in decision-making, these people who are decision-making supporters to reach a decision is generally not recognized under the law and not always offered as a reasonable adjustment in medical practice. And for Audrey, this is discriminatory. So we need to reframe our usual understanding of decision-making capacity in terms of this concept of decision-making capability. So according to this formula, decision-making capability involves ability, and that's what we usually associate with decision-making capacity, plus support. And by supports, it means some of the things we've just been talking about. So from this capability framework, we can expand the typical division in the law between patients who have or who lack decision-making capacity by suggesting that to meet the legal capacity test, we need this third category, which is in the middle, that there is this category of people who have interdependent capability, and with that kind of support of people can meet a test of decision-making capacity. So next slide. So supported decision-making, however, should allow patients moral development and discernment, and this leads to the third ableist bear. So patients with intellectual and developmental disabilities and other cognitive impairments and psychosocial impairments are not offered the guidance they need to identify, prioritize, or express health-related values. And this is an image of Dr. Irene Tuffrey-Wynn discussing end-of-life goals with a patient. In supported decision-making, there can be a tendency inappropriately to apply a consumer model of healthcare. Supported decision makers and medical professionals might avoid deliberating on values with people with intellectual disabilities or other cognitive impairments. So it's presumed that such patients don't learn and can't develop their values. Decision-making vulnerabilities that could be avoided and place such patients in harm's way are sometimes overlooked. So, and just go to the next one. I'm just going to move to the tools. And just advance again. And again. And one more. And again. Yes, so I've just to say that supported decision-making can be difficult to implement. And I want to end by referring to some tools very briefly that can be difficult, that can help with this difficulty and overcome some of the barriers. And the reason I put this slide up first is that this is actually addressing the first barrier, which has to do with the relevance of feelings. And this tool helps understanding and to facilitate discussing feelings and health-related values. Sheila Hollins holds that the biomedical model of mental health, that in mental health, the biomedical model tends to dominate. And this, in fact, is also being used for people with disabilities, which is quite problematic because it bypasses and doesn't attend to what is what she believes is a primary aim, which is people's feelings, and attend to the affective. A second tool that I just wanted to flag is on decision-making in healthcare of adults with intellectual and developmental disabilities, and it's about promoting capabilities. And it provides a capacity assessment that takes into account assessing decision-making capabilities. It documents persons' values and identifies the need for reasonable adjustments and the need for decision-making supporters. And a third tool that I wanted to highlight, and this has to do with the third barrier, is about decision-making in the healthcare of adults with intellectual and developmental disabilities and promoting safety. And it's a tool that screens for factors that undermine decision-making capabilities and place people in some vulnerability. So I've talked about 3 ableist barriers that undermine promoting decision-making capabilities of persons with intellectual and developmental disabilities and persons with other cognitive impairments, and the need to consider reasonable adjustments to how we assess and support these capabilities. I realize, however, that to mitigate ableism in medicine is challenging, and there are several challenges that we need to face. However, if we take seriously our ethical commitments to uphold the respect the dignity of all patients, including those with cognitive impairments, these challenges should be identified in our healthcare organizations and practices and addressed as best we can. And so finally, I just hope in conclusion that this brief presentation has been helpful in meeting the objectives that we started out with, that we are now able to describe and appreciate the importance of mitigating ableism regarding people with disabilities. And that you can recognize the 3 ableist barriers for people with IDD and other cognitive to participating as much as possible in medical decision making. So I poked at the grizzly bear that equates capacity with being able to demonstrate only intellectual skills, the legal bear where capacity has to be demonstrated independently, and the kind of the medical systems care, which employs a consumer model inappropriately and bypasses the vulnerability of people with intellectual and other disabilities. So I just wanted to end by saying that going back to Tim, and through the involvement of group home staff as decision-making supporters, they were able to address the ableist response that was they were initially confronted with the support of his brother. It turned out that he actually was on a respirator for 3 weeks and is now fully recovered and is doing very well. So the very last thing I wanted to mention is a final tool that I think might be helpful because it gets around this whole issue of the legal capacity mental test in order for somebody to participate in decision making. And I'll just mention that we've also developed a COVID-19 advanced care plan. and it's a guide for caregivers and adults with intellectual disabilities. And it goes through this whole process by in a promoting capabilities approach. So finally, I just want to say that I thank you for your attention, and I'm delighted to listen to some questions and maybe get poked a bit myself. Thank you very much.
Bill, thank you very much for such an interesting presentation, and I take it, Bill, that you'll accept pokes, comments, and questions too. So I'd ask anyone who has any of those to indicate to me. Now there is one already, and I have to. Here we. So selection of those who could assist with the capacity question is critical. Do you have advice about selection, Bill? Do you want to get rid of that slide? Sure. So we can just have Bill's face, please, Laura?
Yes, you're right. And it's actually one of the challenges is that it may be that people with the sorts of cognitive disabilities we've been speaking of also have very limited social capital. Has been a term that's used for it. Very few friends who might be appropriate for that role. But it's essentially what you want, and it's kind of spelled out in these tools. You want someone who is known and trusted by the person, and that they're happy for that person to be involved in that way and as a decision-making supporter. And I guess the other thing about this is that person needs to agree and probably needs some coaching, because essentially the role is not well defined, but it would be, in the case of Sesha or Ian or Tim, people who know him very well and can appreciate what his goals, what he's loyal to and committed to, and how that bears upon the particular medical options at stake. So it is an important role. And I guess my final comment is that a very similar thing can happen in advanced care planning. And so, and under less time constraints, and somebody's not like waiting for this precious resource while they're quite ill. So what we've been encouraging people to do is to take this approach, but work it out in advance of getting ill.
Bill, thank you. Now there is another question, but I can't see it. Oh, here we are. The problem of, here's the question, Bill, the problem of fluctuating capacities. A person may have decisional capacity now, but not the capacity to execute decisions,
yes,
such as adhering to treatments. Have you got a comment on that one, Bill?
Yes. So I think I appreciate that very much. And I think that what I've mainly been talking about are people with intellectual disabilities, but of course, even with intellectual disabilities, people can have bad days. But this is particularly a large issue, I think, for people with compromised mental health. So what I've been saying, I've been illustrating with one group and just assuming that similar principles might apply to the other groups, but that actually needs to be, each group has its own specific issues. And I think the issue of fluctuation, one of the things is, the importance of a long-term relationship with somebody, and even during those times when they're better, that's when advanced care planning takes place. Anticipating that there may be a time in the future when decisions might need to be made, and of course they're not as able to participate.
Bill, thank you. And Bill, could I follow up with perhaps we'll make this the last question, a question myself, which is this, that is your claim that this ableism, this attitude of discrimination that devalues people with disabilities, is right throughout medical practice today, or is it something that you recognise, you diagnose in only some practitioners?
Now that's a tough question, and I think one point I would make is that ableism is a type of paternalism, but it's because somebody has, that is in the way it plays out in medicine. It's a type of, doctor knows best or caregiver knows best, but it's because of that person's cognitive impairment. So we're talking about, the care of people with compromised cognitive abilities. And so it may be that, many people in the general population fall into that category, and how we care for them becomes an issue. So that's, I guess, one thing. So is it prevalent in medicine when it comes to people with disabilities, despite all the good advances we've made in getting rid of paternalism in general, and respecting people with disabilities? The other thing, and I think this is even a broader claim, is that ableism is in the very fabric of how we think about care in medicine, because it influences our ethics. Like, how many people talk about somebody like Sesha, who has an ability that should be acknowledged, supported, and it should inform medical decisions. So philosophy, there's very few philosophers who see this capacity that these people illustrate as legitimately cognitive skill. And what I'm saying is that's the key cognitive skill. It has to do with deliberating, which involves values. So there's that, and that's the grizzly bear in the room. But the second bear, that's the polar bear. The second bear is the legal assumption that you have to do it by yourself. And so we have just taken all that in our medical, and it informs our medical practice, and both are, I'm claiming, ableist. So it's a big problem.
It is a big problem. Bill, I think we've run out of time, and on behalf of everybody who's attended Grand Rounds today, I want to thank you very much for giving us such an entertaining and instructive talk today, and for doing so from 10 p.m. on Monday night in Toronto. Bill, thank you very much, and we will finish the meeting now.
Thank you.
So I think, Bill, what happens is that people leave